going to be, this is basically going to be starting where Caitlin left off. As you know, my name is Julie Weiss. I'm one of the R3s in our program. I am also pretty interested in trans healthcare. And I think this is a really fascinating topic. It's a field that's moving really fast. And is going to be something to keep your eye on for throughout our careers, because I think it's gonna change a lot and change rapidly. So I just kind of want to preface, nobody should get too hung up on a lot of terminology. Don't get too hung up on like what we're doing now, because that all may change, but that it is kind of an exciting space to work in, because it's also something that brings people a lot of joy. And something that I've noticed a lot is being in the hospital, especially during COVID times, during a lot of a lot of our patients are getting sicker and having more and more trouble, being able to go to a space where you are literally just making people so happy and you are providing something that's changing their world for the better has been really rewarding for me. So I hope you all can explore the space too during residency, and I hope that you find it as rewarding as I have. Okay, so a lot of the slides I'm going to show today I have not reinvented a wheel too much, and some of it is new, but Cam has done a lot of the heavy labor in creating slide decks, so a lot of credit to him. And I've tried to add a few things here and there, and we'll have a video midway. So let's just get on into it. All right, so gender care. So this is not going to be a 101 talk. We really want to try to provide you guys with information that you can take straight into the clinical space. And also kind of recognizing that, as I said before, that this field is moving quickly. There's a lot of different ways to teach this, a lot of different ways to be a doctor here in this space, and to be a patient or a client that's working through their own gender journey. This should always be centered on the individual and their experience and what they're looking for. And again, I'm not an expert. I've developed an interest in this, and I've done a lot of this sort of without attending oversight in some ways. And so a lot of us have wanted to provide a framework for folks that come after us to have a little more info. One of the things I'm going to be showing a lot of today are just some beautiful pictures. There's a project that was done by a photographer and a professor, so Jess Dugan and Vanessa Fabre, who went through America and took these really wonderful pictures and got the stories of older transgender and non-binary individuals in America. And I would really recommend that you check it out and sort of look at some of these stories, read the stories, and look at the photos. I've put the link in the chat already, and I'm going to kind of reference them throughout. That's called To Survive on This Shore. Okay, so back to our case, and this is going to be a theme that we follow throughout this, all of the talks. So Ash, who was previously on a puberty blocker and had used testosterone for 1 to 2 years during adolescence, has now entered an adult internal medicine clinic for primary care, and they've entered your clinic. They've been using they, them pronouns recently, and had been for a while, had maybe used he, him for a little bit, but really has been using they, them for the past couple of years. You read some of the notes from their astute adolescent medicine physician, Dr. Caitlin Campfield, and you realize that they had the blocker in place for about 4 years. It was removed prior to initiation of testosterone. And then Ash, like many teenagers, was sort of lost to care during late teen, early adult, went to college, has been doing random things, and they have not been on any hormone therapy recently. So even though you may have several transgender patients who are stable on their HRT in your clinic, you're not totally sure how to approach this initial visit. So questions you might have: what name should I use? What are their pronouns? They want hormone therapy. You start to cycle in your head: how do I approach contraception? Do I need to? Have they ever had a menstrual period? Have they had surgeries? Do they want surgeries? You have all of these questions, and you're sort of spiraling into this nitty-gritty of the clinical side. And I just want to back up and remind everybody that the questions they might have are: can I trust this person? Will I be misgendered? Are there going to be outrageous barriers to accessing this care? So just remember to meet your patient where they are and just go from there. And this is a reminder because I have certainly fallen into that former category a number of times. So just some essential intake history. These are things that I have found works well. Other people have found work well. Basic questions that allow you to get to know your patients, right? So what is your gender identity? How long have you identified that way? So you're getting back to this conversation with Ash. Has it been since toddlerhood that you were playing with gender and sort of thinking about this? Or is this something that's come up in the past 2 years? You hit 18, you hit 20, you went to college, and all of a sudden you were like, this is not right. And then name. So you will see somebody's legal name on the medical record. So you need to be asking people, do you have a preferred name that's different than your legal name? And are there pronouns that resonate with you? There may not be. There may be people that are kind of ambivalent about pronouns or care a lot less or have really, really strong feelings about them. I had a patient who was very comfortable using he, him pronouns and then wanted to switch to they, them, and then recently switched to she, her. And I just have found that asking every time that I see people is a really helpful and easy way to go about this to make sure that you are continuing to assess where they're at. Next questions. How long have you been considering hormone replacement therapy? What do you know about hormones? And also, it's really important to know where people are getting their information. The internet is a vast base of knowledge, base of misinformation also of trans care. And a lot of our patients and clients have spent just unbelievable amount of time reading about all of these meds, all of the procedures. They've read studies. There are people that are very, very highly educated, much more so than we are, about what they're wanting, what they're looking for. So making sure to understand what their knowledge base is can cut out a lot of time and can be really helpful, because then you can use your skill set to help to guide them towards things that are going to be healthy and safe. Asking about what their hopes are. Is this somebody who is genderqueer or falls into any of the kind of umbrella of non-binary that just wants to be on a really low dose of testosterone, a really low dose of estrogen? Or is this somebody that wants to have a complete transition as quick as possible, everything done, and is like really raring to go? So these are things that you got to kind of suss out pretty quickly. Always finding out what they're worried about and how they feel about needles is also really helpful. Oh, I'm missing a bunch of stuff in the chat. I just saw. Is there anything that I need to address right now? Looks like it's mostly chit chat.
I think you're okay, Julie.
Okay, cool. All right. So this is a review. I'm not going to go into this. I just want to recenter everybody that gender identity, gender expression, biological sex are all different things. And if you think about them differently, then you can help approach that with the patient really cleanly. So gender identity, womanness or manness, gender expression, are you presenting feminine or masculine? And then biological sex. This is also what we sometimes talk about for ovary-bodied people or testicle-bodied people, or sometimes what Dr. Hatfield over at Polyclinic will say, somebody who went through a testicle-fueled puberty or an ovary-fueled puberty. So there's lots of different ways to discuss this. Again, try not to get too caught up in a lot of the terminology because it's fluid and it may be changing over time, but just realize there are these terms out there. All right. Term clarification of gender dysphoria. I think this is an important one to talk about. So historically, this is a DSM diagnosis of transsexualism. In DSM-3, we no longer think that this is appropriate at all. Moved to being a gender identity disorder in the DSM-4, and now gender dysphoria is a current term. So gender dysphoria is a diagnosis. This is defined as a difference between one's experienced or expressed gender and assigned gender at birth, with also having significant distress or problems functioning in the world. And this needs to be at least 6 months ongoing. There are a few other criteria for this, but this is something that is an ICD-10 code. This is a diagnosis. This is something that's very painful, distressing for the patient. This is a huge quality of life issue, and it puts people at risk for really significant comorbidities. the worst of which is suicide ideation. Now, it's really, really important to just to be clear that transgender identity itself does not increase suicide ideation. There's a lot, huge bodies of literature on this. One, just to pull out one study, there's a Scottish study with about 900 people in it. 63% considered suicide before transition. And this is actually kind of in the median range when you look through the studies about SI prior to transition. Or SI of people experiencing gender dysphoria. And then after transition, this was lowered to about 3%. So this is like an enormous, if you think about all the interventions we do for anything, this is probably the most powerful intervention you could do for somebody in terms of their suicide ideation and comorbidities in the mental health realm. And that somebody who has transitioned has the same suicide risk as general population, which notably is lower than the rates among physicians. And just quickly, not every transgender patient is going to experience gender dysphoria. So remember that if you're treating a patient on stable HRT that transitioned a bunch of years ago, it's probably not appropriate to use this ICD-10 code. And it's also not appropriate to use this if the patient's not experiencing dysphoria. And there are a lot of patients that are maybe more in the non-binary category that may not experience gender dysphoria in the same way. So be careful about how you're coding things in the medical record that our patients can access.
Julia, a question came up about that. So in this case, what ICD-10 diagnosis code would you recommend?
Yeah, so there are a few different ICD-10 codes you can use. One thing that you can do is hormone deficiency. And that's one that I will use for stable. And I don't know if, Harborview is losing money on me putting a code on. I have no idea, but I will put, and this is something that I've seen Kevin Hatfield do for all of his patients over at Polyclinic, is that he codes it as a hormone deficiency. Now, if your patient has gender dysphoria, then it's appropriate to use that. But if they don't have gender dysphoria, then find something else.
Do you ever, or have you seen people talk about, I guess, like the specific diagnosis code with patients? I want to say that like the couple times I've had providers who've talked to me about this is they've, I don't know, just in terms of disclosure and just kind of the frankness of billing and all these different things, they just have a degree of openness. I'm not sure what your thoughts are with that.
Yeah, I think it's not something that's ever been a part of my practice, but one of the nice things about, rotating through some of the community hospitals and community practices is that you can see how they're done in those settings. And over at the Polyclinic, again, with Kevin Hatfield, he has a wide variety of patients, and he will talk very openly about how he codes things so that, because a lot of his patients are folks that are going to be combing through the nitty-gritty of his notes. So he is very open about that, and I've appreciated kind of seeing that modeled. And I think that for things that there may be significant distress coming from, I think it's probably a good idea to go ahead and talk to your patients about this. Yeah, and Hillary's doing a point in here too. So one of the ICD-10 codes for PrEP prescribing is high-risk homosexual activity. So you do not need to use that for PrEP. I use exposure to HIV, and that's what we generally do in the Madison Clinic. And so there are ways to search through ICD-10 codes to find things that kind of suit you. And again, I don't know how much the billing of that matters, but I think since it shows up on patient notes and patients are now able to access our notes, I think it matters. Okay, so readiness. In the past, this has been a letters of support from mental health providers, and really physicians were seen as kind of gatekeepers. Currently, we're using an informed consent model. So this is shared decision-making. There are some really great resources. So UCSF Guidelines actually has this printable, really nice kind of packet that you can sit down and you can actually go through it with your patient. And I would encourage you to do so. And I can put the link in the chat, but it's really, really great, because if you feel stuck, if you feel uncomfortable, if you feel like this isn't something you've done a lot, you literally have like a script in front of you, and you're sitting there with a person in front of you, and you can kind of just go through it together. And I found that to be really helpful for me, especially kind of early on when I was first starting to start people on hormones, to just feel like I wasn't missing a lot of things, but feel like it was kind of all there. Always remember to talk about what's permanent and what's reversible. And we'll talk about that a little bit. And then just again, to be humble, because there are just so many transition blogs. It's all over YouTube. It's all over Reddit. There are these huge forums with discussions of meds and surgeries, how to get there, the cost of it. The online communities, online trans communities are really, really active. Okay, contraindications. There really aren't a lot of contraindications to hormone therapy, but I think it's worth just mentioning a few. If somebody has severe decompensated mental health issue like active psychosis, they probably can't participate in informed consent in that moment. So working on trying to stabilize them first is going to be helpful. This is a little bit controversial, but really significant intellectual or developmental disability that's going to prevent informed consent is something that you should at least think about. If someone has a hormone sensitive malignancy, that's going to be a challenge and is an absolute contraindication. Current pregnancy, unstable, and then there's a couple more here, because a lot of the folks that I've seen over the VA and such have actually transitioned much later in life. So remember, with the people that you're meeting that are a little bit older, to think about things like really unstable ischemic heart disease or decompensated cirrhosis, and think about what the change to hormonal milieu might do. But these are relative contraindications as well. Okay, so now we're going to get into transmasculine transition, and I'm just going to make sure I'm not missing anything else. Okay, so we're going to go through more. So active VTE is not a contraindication to transition. You anticoagulate the person and can continue them or can start them on estrogen. So let's talk about transmasculine transition. And thank you, Cam and Caitlin. If things come up in the chat as I'm going, feel free to just answer it, and then we can kind of be efficient. Or Lindsay. I just saw both of Cam and Caitlin answering things. Okay, masculinizing therapy. This is androgens. This is for somebody who is transmasculine, assigned female at birth, and is desiring the changes that come with testosterone. General effects, you're going to have increased facial hair, body hair, deepening of the voice, subcutaneous fat's going to be redistributed. You're going to have that skin oiliness, oftentimes acne. You will get a change in hairline. So male pattern baldness will appear. Clitoral growth, which this is something that is not reversible. Increase in libido. Cessation of menses, and I put this in red because this actually can take some time for people. A lot will be able to have cessation of menses within a handful of months, but for some it takes quite a bit longer. You'll have vaginal mucosal atrophy. Things it does not do. You're not going to have an increase in height if you start testosterone after having gone through an ovary-driven puberty. You are not going to have a significant decrease in breast size, and you're not going to have reliable contraception. Even if menses has ceased for months or even years, this is not going to be reliable contraception by itself. Other things, this does not cause anger or violence. There are emotional changes. A lot of them are mostly positive, and this is often pretty individual. Androgen formulations. We have a lot of different ones. Usually, so we have IM and sub-Q injections, topical gels, patches, and then a sub-Q pellet There is a PO that's approved. It's not really available. I think the things that you should know as internists would be the most common ones. So testosterone, cypionate or cypionate. This is IM or sub-Q. You can use it either way. This must be injected. Oftentimes we do this weekly. I'll have the next slide will kind of show the timing of this stuff. And then there's gel. This is a 1% gel. This is topical. There's the benefit of no needles, but it is slow drying and kind of messy. You literally kind of spread it on your shoulders and arms, and you must avoid contact with others, or other people are going to get testosterone on their bodies as well and have the impacts of that. This has to be daily use, and it's sometimes more expensive, but can be nice for some people. And then the sub-Q pellet. So this is something that has to be inserted by someone that knows how. I watched Kevin Hatfield do this on one patient, and it's a little tough to watch. I mean, there's multiple pellets, and you're actually inserting them into the subcutaneous tissue in somebody's bottom, and it didn't look particularly pleasant, and it has to be done every few months. But the person who was having this done was sort of talking to me about why, and he was just really feeling done with the injections and wanted to go that route. All right, dosing for our injections. The low dose is going to be 20 milligrams weekly. This is often preferred by adolescents. This is also often preferred by non-binary individuals that are trying to go more slowly. The typical standard dose is going to be 50 per week, or the initial standard dose, and then you will often up titrate somebody to 100 per week. And what you're doing is you're aiming for approximately a midpoint of the reference range for testosterone, which is hugely variable. And that's one of the problems, I think, with a lot of the sort of laboratory monitoring, is that for both estrogen and testosterone, the reference ranges can vary quite a bit. For 1% gel, low dose is going to be 12.5 to 25 milligrams. And this is every morning that people are putting this on. Initial standard dose is going to be 50 milligrams, and the typical is 100. And this can be like 6 pumps of a gel. So this is like a lot that you're putting on yourself. And so that's something that is important to sort of think about. We aim for a midpoint of reported reference range. You're going to be somewhere in the like 75, 100, 150, that kind of range. And then there's really no evidence that super therapeutic testosterone is going to lead to greater virilization. So you're just trying to get into that reference range. Adjuncts. So when folks are taking testosterone therapy, things like male pattern baldness can be unmasked, and hair loss can become a real issue for people. Finasteride is an easy way to treat this, and also some people just don't care and don't mind that male pattern baldness is going to come. A huge question of concern, a huge issue that people are like often really interested in solving as quickly as possible, is cessation of menses. So, or is achieving cessation of menses. An IUD is one of the best ways to do this. You can also do other progesterones, but this is going to be kind of your big ticket. If the testosterone itself doesn't help you very quickly have cessation of menses. Often it will, but if it doesn't, then going for an IUD. If you have menses that are ongoing, you may want to have your patient see endocrine or see OBGYN. Rarely aromatase inhibitors can be used. And then the next part is sort of considering hysterectomy. Sometimes, you can have dyspareunia or dyspareunia or pelvic discomfort. Sometimes this is because you now have some vaginal atrophy. You are not going to have quite as much natural lubrication in the vaginal vault. So you can actually use a little bit of topical vaginal estrogen the same way that we use for postmenopausal cisgendered women. And that can really help. And then, there's a little bit more BV in the estrogen deprived state. Also, just make sure you're, common things being common, checking for STIs and et cetera. And let me just look. It looks like there's quite a bit of stuff in the chat. Anything that okay, I think most of what's in here is going to be is going to come up in the coming slides. All right, monitoring. You want to do, so you have all of your standard monitoring for the other indications that this patient may have, but specifically for a transmasculine transition, what you want to do is a baseline H&H. And the reason for this is that you can get elevations in hematocrit with testosterone. And then at your 3-month visit, you're going to check an H&H. You want to measure a testosterone level. And then at 6 months, H&H and testosterone 1 year. And then after that, you can just do yearly because you've probably achieved a steady state. You have the person where you want them in terms of the dose, and then you can just measure from there. Now, this is a little bit controversial because some people will tell you that why would you continue to check testosterone if you're seeing the changes that you want and your dose hasn't changed? And I think that makes those of us lab checkers a little bit nervous. We like to have our numbers, but just consider what that test is actually giving you. I think it's pretty reasonable to do annual labs for people. It's not a huge burden. And then just per guidelines, continuing to do the regular healthcare maintenance. Okay, effects of testosterone and when and how you're going to see these. So the skin changes are reversible. You're going to see them quickly. This is going to be one of the first things that you see, 1 to 6 months with a maximum at sort of 2 years. The deeper voice you're going to see quickly too. This is going to be something that within the first few months will start, and really, by 2 years, we'll have kind of the maximum effect. Body fat, this is, and the deeper voice I want to point out, that is irreversible. Body fat, this is pretty variable, and it will start pretty quickly. Muscle mass, sometimes folks find that they have been working on a gym and that they're starting to see better muscle definition and mass within the first 6 months. And then the other things that I just want to really point out is cessation of menses happens oftentimes pretty quickly for people. And there's some good studies that have shown that for the vast majority of folks that start on testosterone, that this will happen within the first few months for them, and then some stragglers, as I talked about before. Clitoral enlargement. So this is irreversible, and this is important to know and important to counsel patients that this is irreversible, and it is the clitoris will grow significantly. Cam has more slides that kind of show some pictures of this, so I'll save a little bit of that for his talk. And then infertility, and this is something that Lindsay's going to talk about a little bit more too. This is pretty variable, but this can happen pretty quickly too. Okay. Just some special considerations. Migraines can be associated with fluctuations in estrogen levels, so people can start to have migraines. You really want to, if you're seeing this with your patient, start low, go slow. As the estrogen levels are suppressed, and as testosterone is kind of reaching a steady state, you will see less of this. But if these are really debilitating, then you want to go pretty slow. And then you can also use transdermal preparations. So the gels, you're going to have less fluctuation in the testosterone than doing something once a week, doing an injection once a week, and therefore less fluctuation in estrogen levels. So that's something that you should consider. And then polycythemia. So Just make sure that the testosterone dose is therapeutic. If you are seeing somebody's hematocrit start to rise, you will need to rule out other pathologic causes of polycythemia because we're not having a vacuum here. They could have other things going on, neoplasm, sleep apnea. And then some people manage this with blood donations. But you want to just make sure that this is sort of a diagnosis of exclusion, that it's being caused by the T. So make sure to work it up appropriately. Just going to go through so our panels check free T, check kind of everything, but so I usually just order the panel. And if there is concern about I think that they are pretty decent, the calculators that use total T. Great. Okay, so I just want to highlight that if you are interested, and I think everyone here probably is, if you do spend some time on YouTube, if you do spend some time looking through Reddit, et cetera, what you'll find is these like really beautiful photo essays about people's transitions. And this is one that I will just kind of show, like this is kind of all across the internet, but people will have a lot of celebration and joy in their transition. And so it's something that I think is important to just pause and remember. We are in the business here of creating joy. We are in the business of helping people achieve something that they have really wanted for a long time. And it's easy to get caught up in the nitty-gritty of the clinical side, but just remembering that this is really a humanistic journey that we are on with our patients. Okay. Ash, our patient, now is leaving this initial visit feeling ready to start T or restart, as they haven't been on T for some time. With your guidance, they have decided to start injections, so this isopionate, 50 milligrams per week. You see them at the first 3-month visit, you do H&H and T levels. Ash is super pleased that their T is now 75, so it's kind of getting up there, starting to notice some changes like voice deepening, some thicker body hair. They tell you near the end of the visit that they're really happy so far, they're excited about more. In this visit, you readdress pronouns and gender identity with Ash, and you learn that Ash has made a decision to now use he, him pronouns. You change this in Epic immediately, and you have a quick celebration with Ash as he is already feeling more congruent in his body and his mind. So look what you've already done for this person. You take a minute after the visit, you realize how fulfilling it was to see these positive changes in a primary care visit. And just like in all primary care, you realize something that you missed. You forgot to ask Ash about contraception. Because it's a sticky topic, it's something that's you have sort of put in the back of your head as, even though it's important, it's something that can be uncomfortable to ask somebody who is going through a transition like this. So Lindsay's going to talk about this more, but I'm sort of teeing that up. Okay, so at this point right now, I am going to play a video, about 5 minutes of a video. It's just sort of like a break in it, and then we're going to come back and do a transfeminine discussion and go through kind of what I just did, but on the other side. This is something, though, that I think everybody should watch. So if you have a quick sec, kind of get more comfy, we're going to do about 5 minutes of this. And
I'm a transgender woman, and my dream was always to be
queued up. Okay, so just really quickly, I can see Lindsay. Can you hear what I'm playing? You can hear it. Okay,
we can hear it, but we can't see it.
We can't see it. Okay, so I need to do a screen share differently. So I will share my desktop then. Okay, now can people see?
Yep, we can see it now.
Okay, cool. Which one is the full screen?
No, it's AirPlay.
Ooh, that was AirPlay. This one.
Right, far right.
Yep, that one.
Okay, so can people hear and see really quick?
Yep.
Can I get a yes? Okay, cool. So we're going to do about 5 minutes of this. This is something that so there's a YouTuber named Jamie who is a trans man. This video has almost 1 million views, and he has a channel that is filled with different tidbits from his transition, as well as tips and tricks for other guys that are kind of earlier in their transition. And this is actually a video he put together about his whole transition, and it's really sweet and awesome. We're not going to watch all 9 minutes, don't worry. It's about 5 minutes that we'll show. All right.
Okay, so this is about my 3rd time trying to make this, and I don't know, I just never know what to say. Hey, my name is Jamie. I'm just making a female to male intro video. I am pre-everything. Hey, so I am officially on testosterone today. 25th of January 2012 is my T-day, so I am so excited. So this is my 1 month on testosterone. I have had quite a few changes, just small ones that aren't really noticeable. I think my voice has dropped a little bit, and I've been getting spots, as you can see, just here and like round here. 2 months on T video and just some changes. Well, the first one is I've had a definite voice drop in the last month, and I'm just like so much more confident now. This is my 3 months on testosterone update. I think the first change that's quite noticeable is my voice. It's breaking as well. Today is my 4 months on testosterone. The hair on my arms has increased a lot, and my legs as well, it's starting to grow over my knees. 5 months on testosterone video. It was my 5 months yesterday. This is my 6 months on T video, and I can't believe it is 6 months already. I'm still getting lots of body hair coming in. Hey, it's Jamie. It's my 7 months on T video. It's a bit late, but I've been distracted with top surgery and stuff. My facial hair is increasing. It's getting dark on my chin. 1 month post-op video. I think it's healing really well. It just feels amazing to be able to be topless and wear vest tops and stuff. Hey, it's Jamie, and this is my girlfriend. This is my 8 months on T update. The changes are really slowing down. I don't really notice much. I think my voice is still dropping. I do have one proper facial hair now. This is my 1 year on T video. I can't believe it's been 1 year already. It doesn't feel like it's been a year. Today is my 6 months post-op, so I thought I'd make an update on my chest. It's been doing really well. My chest looks over on the side, this side. Hey, it's Jamie. I'm now 18 months on T. I've been thinking about changes, and there really hasn't been any like big changes since a year or anything. I mean, my face shape has changed a little bit. It's been a few months since I've made a T update. I think it's maybe closer to 4 now actually. The hair's really coming in on my chest now, and also facial hair, which is really cool. I've been waiting for that for 2 years, and it's finally coming in. Hey, it's Jamie. I am now 2 years post-op, well, a couple of days off, but I'm not going to be able to make this on the actual day, so I'm making it a bit early. So I'm now about 3 years, 9 months on T, and my facial hair is quite filled in. It's still filling in more now, but like the patch under here is filled in quite a bit. My sideburns are coming in more, and like it's filling in here as well. Oh, it's weird recording with me. Go on, just do it. Okay, hey, it's Jamie, and this is the parent Q&A, and this is my mum.
Oh,
Hello, today I'm here with my dad. Four years anniversary of being post-top surgery. Okay. Hi. So, yeah, something big's happened. I have had bottom surgery.
He's been in his bed for a little while.
We've got little Tommy Dangle there. There's a very fetching a drain.
I am so close to being 6 years on testosterone, which is insane. Hey guys, I'm now 1 month post-op, first stage metoidioplasty, and today I'm joined by my older brother. Oh man, this is giving me flashbacks. Okay. I've had surgery again. I now have 2 balls. I have balls.
He's back. He's back. I'm so happy. Look at my Jamie, and he's 2 plums heavier. We've been together 8 years.
Yes, I'm pretty sure. And also, this has been in the making for 8 years, because I've been can't even speak, transitioning for just over 8 years. And I feel like this is like the juicy ending. I applied to change my birth certificate so that we can get married properly.
And also
And,
so
like,
you could be recognised.
And yeah, legally, which is very important. And I don't know, they just send you a letter. I've been checking my emails even though I know it wouldn't come in an email because I knew it was happening whilst we were away.
I'll stop recording now. Okay, we're back. A few happy tears, a few overwhelming tears, but we've got it. Yeah.
Yeah. Congratulations on your gender recognition certificate. Male. I finished the physical side of my transition, which was emotional, and this kind of like ties up that last loose end, just to say like this is done. It's over 8 years.
That was your bonus boss level. You're done. There's nothing else to do. Disclaimer, not that I'm saying you have to do all stages. Okay, just saying for Jamie.
Congratulations, it's a boy!
My birth certificate.
2 balls. 6 years bottom surgery. 6 months post-op. 1. Go to be double 6 months quarantine.
I'm officially on testosterone today.
Okay, I think there's a little bit left of this video that you all can peruse on your own, just Jamie talking now at this period of time. But that is the video. Any comments on the video before we move forward? Okay, and that's basically, YouTube is full of those. That one is, like, I think, really, really good, really well done, obviously, really beautiful and really emotional, but also just a really good reminder to us that we are literally changing people's lives. Okay, so to go into feminine transition and switch gears just a little bit. So feminizing therapy. And our case does not necessarily apply to this person. So we're going to just go caseless for a little bit before we come back to Ash. So feminizing therapy, the goal of feminizing therapy. So this is going to be using estrogen. It's going to be using an androgen blocker, and sometimes it's also using progesterone. And I'll go through all of those. General effects of feminizing therapy: breast development, reduction in that muscle mass, redistribution of body hair, a softening of the skin, decreased erectile function will happen, reduced or absent sperm count, testicles will atrophy, will shrink, the size will be reduced, some emotional changes, and then again, does not change height. If you went through a testicle-driven puberty, then your height is not going to be changed by induction of feminizing therapy. Does not eliminate facial hair growth, does not alter facial bone structure, move the laryngeal prominence, and also does not provide reliable contraception. And I think really importantly for a lot of folks, and this really ties into Caitlin's presentation, is that this does not raise voice pitch. And voice pitch is something that trans women have to deal with for their whole lives because it's largely voice coaching. Okay, estrogens. So there are estrogens of yesteryear and estrogens of today. I'm going to focus on the estrogens of today because that's what we're going to be prescribing. And I don't want to spend a lot of time talking about why we don't use older preparations. So we use 17 beta estradiol, which is bioidentical estrogen. This is the same thing that's used for agonadal or menopausal patients. This is something that's been around for a long time, and we have a lot of safety profiles on it. It's available as a transdermal patch, an oral or sublingual tablet, or injection of a conjugated ester. I have used with my patients the patch, the tablets, and injections, all three of them, with a lot of different folks with good success, and it's largely going to be a preference thing. So oral or sublingual, the low dose you're going to start with is 1 milligram daily. An initial start dose, and again, so these low doses are sometimes what we are going to be using for folks that want to go really, really slowly, or folks that are non-binary and not looking for a rapid transition. So the initial standard dose is going to be 2 milligrams daily. You can also have 2 milligrams BID that you start with. So that just depends on how often the person wants to take the pill. And then generally speaking, we think about 4 milligrams BID or 8 milligrams in a 24-hour period as going to be the max dose. Estradiol transdermal, these are going to become in patches that people put on their bodies, oftentimes around the waistband or on the shoulder, et cetera. The initial kind of standard dose that we start with is about a 100 microgram patch. Having 4 patches on at once is really excessive, and people don't like that. So it tends to be that if you require more than kind of 1 patch, that you would go to a different formulation. Estradiol valerate. This is, I think, what I have used the most frequently, with an initial standard dose being 20 milligrams, and this is IM every 2 weeks. I have a few people that are on 40 or 20, depending on kind of their lab values that have come up in our monitoring period. And if you prefer to have less of sort of kind of cycling feeling to it and more even, then you can divide those into weekly injections. And so I have a few folks that they're on weekly, and a few that just don't want to give themselves as many injections, and so do every 2 weeks. And then the other one is estradiol cypionate. This is also IM, and it's kind of similar, but the doses are quite a bit different. You are going to titrate to physiologic female levels. Wow, that is a huge, huge range. That is a monster of a range. So this is really hard to get to. And what I have sort of developed in my head, and this is, there's UCS guidelines, there's a lot of different guidelines on this, endocrine societies, but you want to try to get them above 100, but you certainly don't want them to be up in the 500 or higher range. So really trying to hit that kind of sweet spot, 150 to 200, that's going to be hard to do. It's a little bit challenging, but that's going to be sort of your best range. There is, again, no evidence that supertherapeutic estrogen levels lead to greater feminization. And I have had patients ask, well, I really want to get my levels higher. And so that's something that you're going to kind of constantly have to, well, not always constantly have to talk about, but it is something that you should know so that you can counsel your patients appropriately. This is a really sweet little old lady with a model airplane. Antiandrogens. These can be used without co-prescribed estrogen in patients that just want to start with reducing testosterone levels. So you can start with spironolactone alone for months and months and months, and then add estrogen when the patient is ready. So this comes back to personalized medicine for this and really talking to the patient about what they want. Antiandrogens, going to be associated with some hot flashes, low mood or energy. And then long-term antiandrogen monotherapy will result in bone loss. So this shouldn't be your kind of long-term plan without having some pretty careful discussions with your patient. The most common one that we use is spironolactone. You can also use 5-alpha reductase inhibitors. That's going to be a little bit less effective. There's a lot of, I would say, chatter in the blogosphere and Reddit sphere about spironolactone, and a lot of girls are turning away from it, thinking that there's this brain fog, thinking people don't feel great on it. It's a little bit hard to tell what's real and what's not there. I think, I have one patient who was on spironolactone and was coming in and like her blood pressure was like 85, 90. And I was like, yeah, I think you're probably not feeling great because of the spironolactone. Let's switch it to something else. So just remembering that for young patients that may have lower blood pressures to begin with, you're adding a diuretic and a blood pressure agent. So to kind of consider that. And then the ultimate antiandrogen is going to be gonadectomy. And if you have a gonadectomy, you do not need any antiandrogen from there forth. And we will talk more about surgeries later. Dosing for antiandrogens, spironolactone. I usually start people on 50. I usually start people on 50 daily and then up titrate it to 50 BID once I know that they can tolerate it. You really should not be going over a max dose of 200 milligrams BID. If you are finding that your patient does not have suppressed testosterone levels on 200 BID, then you should be adding something to this. And so you can add finasteride or dutasteride. There is sort of a preference for dutasteride in the UCSF guidelines. And I'm not totally sure why. I think maybe it's effectiveness, but it's much easier to get finasteride. It's cheaper. I would recommend using finasteride because it is like a very easy generic medicine to find everywhere. And you can start this at 1 milligram with a max dose of 5. So I have one patient that I have on a pretty high dose of spironolactone, and I have on, I think, 2.5 of finasteride as well. You are trying to suppress testosterone. You're trying to totally suppress it. And so you want that to be less than 55. You ideally want it to be closer to 0 as well. Okay. I have like a fly in front of my face. Sorry. Okay. The next one is going to be progesterone. So you don't have to add progesterone to your patient's med list. This is something that I usually don't offer. It's often something that somebody brings to me and says, I have read a lot about progesterone. I don't feel like I'm getting any more benefit from, in breast development from estrogen. I've been on it for a long time and I want something different. I've heard that progesterone helps with breast development. So that is essentially the reason I have heard people wanting progesterone. There may be others, but that is like the big kind of thing that I have heard. The effects are really variable though. You may get a little bit of breast augmentation. Certainly there's potential that areola development is going to be impacted, but the effects are going to be super variable. Generally, this is going to be an oral tablet. Depo-Provera is going to be a lot less common. So we usually do this in the medroxyprogesterone acetate. And we start people at 2.5 milligrams nightly. This is what's usually used. You can go up from it. It's a little bit unclear what kind of bang for your buck you're really going to get. But this is an option for people. And then I don't have much experience with the micronized bioidentical progesterone, which is the Prometrium, but it's also an option. Okay, this is sort of similar to our last slide that showed the opposite effects. So this is with an antiandrogen and an estrogen together. So I think the main thing to know that's irreversible is going to be the breast development. Okay, that's going to happen. And if that is something that is desired to be removed, then it has to be surgically removed. Variable, So let's just kind of go through this. So the softening of the skin and decreased oiliness, that's reversible. This is going to happen pretty quickly. The body fat redistribution also pretty quickly, as well as muscle mass. The body and facial hair is going to be something that's ongoing for a lot of years, though, to get the maximum effect. And then male pattern baldness may actually show up pretty quickly in people. Testicular volume and erectile dysfunction are things people tend to ask about quite a bit, as well as the decreased sperm production. And this is really variable. So you need to counsel your patients that this can happen pretty quickly on these medications. Here's just a diagram of before estrogen, a handful of months on estrogen, and then a year or maybe up to like multiple years on estrogen, what somebody can expect as far as breast development. So a lot of talk around how large are my breasts going to get. The typical advice is to look around to family members and cisgendered female family members. What kind of breast development they have is something that you can potentially expect. Larger BMI is always going to have larger breasts. That's just a fact, kind of no matter what. That's independent of genetics. And so for some trans women, they are actually interested in gaining some weight in adipose because it will help with the breast development as well. Okay. All right, special considerations, fertility. So this is going to be a big one, and Lindsay's going to talk about this a little bit more, but sometimes people just feel like they really need to transition now, and it has to happen, and it's really a life-saving measure in some ways. And so you may not have the buy-in to really talk about sperm banking, but it is something that's important to at least bring up and at least offer, because you don't really know what their potential for fertility is going to be after you start these medications. Okay, so considering sperm banking prior to initiation, and having just a good conversation with somebody about if they have any interest at all in having kind of their own biological children, as it were, then this is something that needs to be considered. And then post-orchiectomy, this is just pretty clear. So you can actually totally stop the antiandrogens. Generally, there's not a change to the estrogen and progesterone, although one of the endocrinologists at the VA does tend to find that he goes down on estrogen over time. And then tobacco use. So this is a lot of questions around tobacco use. So there is an increased risk of VTE in combination with estrogen. This is not an absolute contraindication, though. One of the things you can do is you can use the patch to minimize risk. And that's something that I think just needs to be a really clear, good conversation between you and the patient about how many cigarettes they're smoking, what their risk really is, and sort of think about it that way. And if people are not wanting, if they're okay with the patch and are smoking a few cigarettes a day, then that's one kind of reasonable solution. And if they really want to do other methods such as oral, then you can talk about including aspirin, which has been shown to kind of reduce that risk. But this can also be a good time just in life to talk about smoking cessation with your patients. All right, and then monitoring. So at baseline, if spironolactone is used, you're going to want to get a BMP for all the reasons you get a BMP for spironolactone and all the other indications that you have. For every 3 months, you're going to get E levels, total T, and a BMP. At 6 months, again, E, total T, and a BMP. And then yearly, you can actually drop the estradiol, and you can just make sure that you have testosterone suppression and a BMP if you're going to be continuing to use spironolactone. Now, I polled the trans health attendings about this and basically got a completely different answer with everybody that I asked. So this is a space that may have more evidence and more kind of guideline updating as we go. A few of the endocrinologists were totally split. I monitor everything at every 3 months, no matter what, or I only do yearly. And if somebody's on a steady dose, of their meds and is seeing desired changes, then I don't ever check after, 6 months or a year period. So I think that this is pretty variable, and we may have more guidance in the upcoming years. And this is just another example. This is from Ottawa. This is a guideline from one of the endocrine societies in Canada. And this is really, really sort of giving a much larger number of lab studies to check, which is CBC, your LFTs, fasting glucose, lipids, and then prolactin and LH. And nobody else that I talked to was checking prolactin and LH routinely. And then a plug for what about HIV. So we know that trans women are at much higher risk for acquiring HIV than many other demographics. So I would highly recommend that you do HIV screening if the person is at risk. Really talk to them about their sexual practices. Talk to them about if they are trading sex for money or for other things, and do routine HIV testing, and also offer PrEP. So a way that I have met a few of my trans patients is through PrEP. So please try to engage your patients in these other topics. Okay, and then lastly, for this topic, I wanted to talk about breast cancer screening. So there's a sort of a variety here, but I do kind of want to make sure that this is covered. So is this person on hormone therapy? No, screening is not necessary. Less than 5 years, screening is probably not necessary. But once somebody's been on estrogen-based hormone therapy for more than 5 years, then you want to really separate this out into their age. If they're less than 50, screening is probably not necessary. This may change in the future as we see people that have been on these therapies starting in adolescence. So I would expect that this may change. And then here in the 50 to 69 of age, if somebody has breast implants, then we would recommend mammograms every 2 years. Without breast implants, again, mammograms every 2 years. And then if you have silicone injections, then the best way to screen is probably going to be MRI and ultrasound, and probably every 2 years there too. Okay, and I realize that I am out of time here. So what I want to say about non-binary gender care is the principles that I have presented earlier in this talk apply, but what you need to do is you just really need to ask the person what they're looking for and what they want. And it may be a really wide variety of things. And so this is just where continuing to, every time you see them, really understanding what they're looking for, because that may change over time too, and trying to meet them where they're at. I think the big thing is going to be, it's usually appropriate to go really slow. You can also take breaks, and then always make sure to tell people that you can't pick and choose what parts of these changes are going to happen to their body. So, and that is sometimes really hard for people. If people really want to keep the erections that they're able to have, but would like other things that estrogen can provide, it can be really challenging. So making sure to just listen to them and ask what they want, how you can kind of best help, obviously. And then also just a note that people who are non-binary may not have the same gender dysphoria you've seen in patients that are kind of fall under the more classical terminology of transgender. So just kind of try to understand what they are interested in. All right, and then back to our case. Ash comes back for his 6th and 9-month appointments. His voice has now deepened. He's been working out at the gym. He is super excited to show his new 6-pack. He's got facial hair growing at his chin. He's excited to tell you about this genderqueer person he started dating, and he wants to talk about next steps in his transition. You ask about Menses. They've completely stopped, and he has been using condoms for contraception when having vaginal intercourse. you have, since you have such good rapport, you start discussing what else could help Ash feel more congruent with his body. And he brings up top and bottom surgery. And he is also ready to talk more about reproductive health. And from that, I will segue and I will put more resources up later when we send this out. But I will conclude my part of the presentation and take questions.
Hey, Julie, can you hear me?
Yeah.
My question, you mentioned in your last a bit about feminizing hormone therapy, about using spironol lockdown and finasteride. Do you do that only for people who don't have adequately suppressed T, or is there other benefit of finasteride on top of spironol?
Inadequately suppressed.
Okay.
But again, I'm not an expert. There may be other reasons. And so if anybody else wants to speak out, go for it.
The question my patient had was about if there was any extra benefit for with hairline and stuff like that with using finasteride. And my impression was that if your T is suppressed, there's not anything for, to be converted. That would affect your hairline.
Yeah. I think that that's true. And remember that if you are giving somebody estrogen, the estrogen will also reverse some of that male pattern baldness that the person might have had before.
Thank you.
Okay, so should we move on to the next part of our presentation, or how do you guys want to do this?